Leydig cell tumor is a rare neoplasm that originates from hormone producing Leydig cells. In males, these cells sit in the interstitial compartment of the testis and synthesize testosterone. In females, similar cells are found in the ovarian stroma and produce estrogen. The tumor may secrete excess sex steroids, leading to systemic effects, and often presents as a painless firm mass that can be felt during self-examination or routine clinical exam. Because the growth is typically slow and may be hormonally active, patients sometimes notice hormonal changes, such as breast enlargement in men, before the physical lump becomes apparent. The precise cause of most Leydig cell tumors remains unknown, classifying them as sporadic. However, several risk factors have been identified. Genetic syndromes, most notably Carney complex, which involves mutations in the PRKAR1A gene, predispose individuals to multiple endocrine tumors, including Leydig cell neoplasms. Occupational exposure to certain industrial chemicals, such as organochlorine pesticides or heavy metals, may disrupt endocrine signaling and promote tumorigenesis. Hormonal imbalances, such as prolonged elevated luteinizing hormone LH or exogenous androgen therapy, can also stimulate Leydig cell proliferation. Think of the tumor like a weed that appears without a visible seed, driven by hidden genetic or environmental disturbances. Leydig cell tumors retain the ability to synthesize and secrete sex steroids, irrespective of physiologic feedback mechanisms. In men, autonomous production of testosterone can suppress gonadotropins, LH and FSH, while still leading to peripheral conversion to estrogen, causing gynecomastia. In women, excess estrogen may cause menstrual irregularities or even precocious puberty in children. The tumor mass itself expands by proliferating the Leydig cells, which may compress adjacent seminiferous tubules in testes or ovarian follicles, potentially leading to local pain or dysfunction. Rarely, tumor cells acquire invasive properties, breach the basement membrane, and disseminate via lymphovascular channels to lungs, liver, or bone, reflecting a shift from a hormone-driven benign lesion to a malignant one. Leydig cell tumors account for roughly 1 to 3% of all primary testicular neoplasms and an even smaller proportion of ovarian tumors, making them a rarity in clinical practice. The incidence peaks in adult males aged 30 to 40 years and adult females aged 40 to 50 years, though pediatric cases can occur and commonly present with precocious puberty. Geographic distribution appears uniform, with no clear ethnic predilection. Because most cases are benign, many are discovered incidentally during imaging for unrelated reasons, contributing to the low reported prevalence. The most frequent presenting sign is a firm, non-tender, palpable mass within the affected testicle or ovary. Hormone-related manifestations often dominate the clinical picture. Men may develop gynecomastia, decreased libido, or erectile dysfunction due to estrogen excess. Women may experience irregular menstrual bleeding, breast tenderness, or signs of estrogen excess, such as bloating. In prepubertal children, rapid development of secondary sexual characteristics, for example, facial hair in boys, breast development in girls, may be the first clue. Occasionally, patients report a sensation of heaviness or dull discomfort in the scrotum or pelvis, but true pain is uncommon. A thorough history focuses on the onset and duration of the lump-associated hormonal changes. For example, breast growth, voice deepening, family history of endocrine tumors, and any exposure to potential environmental toxins. Physical examination includes careful inspection and palpation of the scrotum or pelvis, evaluation of breast tissue for gynecomastia, and assessment of secondary sexual characteristics. The clinician also checks for lymphadenopathy and signs of metastatic spread, such as respiratory symptoms that may hint at pulmonary involvement. High-frequency scrotal ultrasound is the first-line imaging modality. Leydig cell tumors appear as well-defined, often hyperechoic solid masses that may have internal vascular flow on Doppler study. When ultrasound raises suspicion for extratesticular extension or lymph node involvement. Cross-sectional imaging, contrast-enhanced CT or pelvic MRI, provides detailed anatomic mapping, assesses tumor size, evaluates involvement of adjacent structures, and detects distant metastases. MRI is particularly useful for ovarian lesions, offering superior soft tissue contrast to differentiate Leydig cell tumors from other stromal neoplasms. Serum hormone panels reveal markedly elevated testosterone in men, often greater than 10 nanograms per milliliter, or estradiol in women, sometimes accompanied by suppressed gonadotropins, LH, FSH, due to negative feedback. Additional biomarkers such as inhibin B, a protein secreted by Leydig cells, may be markedly raised and serve as a tumor-specific indicator. Conventional germ cell tumor markers, alpha-fetoprotein, a FP, beta-human chorionic gonadotropin, beta-HCG, and lactate dehydrogenase, LDH, are typically normal, helping to distinguish Leydig cell tumors from other testicular malignancies. Definitive diagnosis requires microscopic examination of a tissue specimen obtained via surgical excision or core needle biopsy. Classic Leydig cells are polygonal with abundant eosinophilic cytoplasm, round nuclei, and occasional Reinke crystals, rod-shaped, brightly eosinophilic inclusions that are pathognomonic when present. Immunohistochemical staining reinforces the diagnosis, strong positivity for inhibin alpha, calretinin, and melan A, together with negative staining for germ cell markers PLAP and OCT4, confirms a stromal Leydig origin. The presence or absence of atypia, necrosis, and high mitotic rate helps to stratify benign versus malignant potential. In males, Leydig cell tumors arise within the interstitial compartment of the testis and predominantly produce testosterone, often leading to androgenic or estrogenic effects due to peripheral conversion. In females, the tumor originates from ovarian stromal Leydig cells and usually secretes estrogen, causing menstrual disturbances, uterine bleeding, or signs of feminization in children. Despite the anatomic differences, both share similar histologic features and generally follow the same clinical algorithm for assessment and management. The majority, approximately 90% of Leydig cell tumors behave benignly, remaining confined to the organ of origin without invasive growth. Malignant transformation is signaled by several histopathologic criteria: tumor size greater than 5 centimeters, infiltrative margins, high mitotic index greater than 5 mitoses per 10 high power fields, necrosis, vascular or lymphatic invasion, and presence of distant metastases. Clinically, malignant cases present with rapid enlargement, pain, and systemic symptoms such as weight loss or respiratory complaints from lung metastases. Prognosis diverges sharply. Benign lesions have greater than 95% cure rates after complete excision, whereas malignant disease carries a 5-year survival of roughly 50%. Surgery remains the cornerstone of therapy. Standard radical inguinal orchiectomy, removal of the testis and spermatic cord, is recommended for most testicular Leydig cell tumors, ensuring complete excision and accurate staging. For ovarian involvement, unilateral oophorectomy is performed, preserving the contralateral ovary when fertility is desired. In selected patients with small less than 2 centimeters, well-circumscribed, and clearly benign lesions, testis-sparing surgery, enucleation, can be attempted to preserve hormonal function and fertility, provided intraoperative frozen section confirms benign pathology. When hormonal excess causes distressing symptoms, pharmacologic modulation is useful. In men, Antiandrogens such as flutamide or bicalutamide block androgen receptors, reducing gynecomastia and tenderness. Aromatase inhibitors, letrozole and anastrozole, lower estrogen conversion, also alleviating breast growth. In women, aromatase inhibitors or selective estrogen receptor modulators, tamoxifen, counteract excessive estrogen production. Hormonal therapy is generally adjunctive, used when surgical resection is incomplete, when the tumor is unresectable, or for symptom control in metastatic disease. Chemotherapy is reserved for malignant Leydig cell tumors that have metastasized or are unresectable. Regimens borrowed from other germ cell and soft tissue sarcoma protocols are employed, most commonly a combination of cisplatin, etoposide, and ifosfamide, the VIP regimen. Response rates are modest. Thus, chemotherapy is considered palliative or a bridge to surgical debulking. Dose adjustments are necessary based on renal function and prior exposure to nephrotoxic agents, and supportive care with antiemetics and hydration is mandatory. Supportive care with antiemetics and hydration is mandatory. Leydig cell tumors display relative radio resistance, making radiotherapy an uncommon choice. It may be employed in cases of residual microscopic disease after surgery, when the tumor is located in a surgically inaccessible region, or for palliative control of painful bone metastases. Low-dose external beam radiation, 30 to 45 gray, can shrink residual nodules, but careful planning is required to spare surrounding gonadal tissue and preserve fertility when possible. Post-operative surveillance aims to detect recurrence early. The schedule typically includes physical examination, scrotal or pelvic ultrasound, and serum hormone measurement, testosterone or estradiol, inhibin B, every 3 to 6 months for the first 2 years, then annually thereafter. Imaging, CT or MRI, is added if any clinical or laboratory abnormality arises. Long-term follow-up is essential because late recurrences, particularly in malignant cases, can occur beyond 5 years. No specific primary prevention exists because the etiology is largely sporadic. However, mitigation strategies focus on reducing known risk exposures, avoiding occupational contact with endocrine-disrupting chemicals, for example, organochlorine pesticides, certain solvents, using protective equipment when handling hazardous substances, and instituting regular health screenings for individuals with hereditary syndromes such as Carney complex. Early detection through routine testicular self-exam or pelvic imaging in high-risk groups can improve outcomes. Benign Leydig cell tumors have an excellent prognosis, with cure rates exceeding 95% after complete surgical excision and minimal risk of recurrence. Malignant lesions carry a more guarded outlook. 5-year survival ranges from 30 to 55%, depending on tumor stage, metastatic burden, and response to chemotherapy. Early-stage disease confined to the primary organ has the best outcomes, whereas distant metastases, especially to the lungs or liver, markedly diminish survival. Ongoing hormone monitoring helps identify recurrence before clinical symptoms develop, thereby improving long-term management. High-throughput sequencing studies have uncovered recurrent somatic mutations in the KIT tyrosine kinase receptor and HRAS oncogene in a subset of Leydig cell tumors. These alterations activate downstream MAPK and PI3K ACT pathways, driving uncontrolled proliferation and possibly influencing the tumor's hormonal phenotype. Molecular profiling now enables classification of tumors into distinct genomic clusters, predicting aggressiveness and offering a rationale for targeted therapeutic trials. Targeted agents that inhibit KIT, for example, imatinib, sunitinib, or MAPK pathway components, MEK inhibitors, are being evaluated in early-phase clinical trials for patients with refractory or metastatic Leydig cell tumors harboring the corresponding mutations. Preliminary results demonstrate partial responses and disease stabilization in a minority of heavily pre-treated patients, suggesting that precision medicine could become a viable option for genetically defined subsets. Research is focused on identifying serum biomarkers that reliably separate benign from malignant Leydig cell tumors. Elevated inhibin B levels, combined with circulating microRNA 210, have shown promise as a composite predictor of aggressive behavior. Such non-invasive assays could guide clinicians toward more intensive surveillance or early adjuvant therapy, reducing reliance on invasive biopsies. Checkpoint inhibitors such as pembrolizumab, anti-PD-1, are being explored in small case series for advanced Leydig cell carcinoma that expresses PD-L1 or harbors high tumor mutational burden. Early anecdotal responses include partial tumor shrinkage and symptomatic improvement, although durability remains uncertain. Ongoing trials aim to define biomarkers of response and optimal combination, strategies with chemotherapy or targeted agents. Robotic-assisted laparoscopic orchiectomy and oophorectomy have become feasible for small, well-localized Leydig cell tumors. These techniques use articulating instruments and three-dimensional visualization, allowing precise tumor excision through 5mm ports, reduced postoperative pain, shorter hospital stay, and quicker return to fertility-preserving activities. Studies report comparable oncologic outcomes to open surgery, while enhancing cosmetic results.